Hi, welcome to Medscape UK. My name is Mamas Mamas. I'm Professor of Cardiology from Keele University in the United Kingdom, and I'm going to talk about the highlights of the European Society of Cardiology held in Paris 2019. This year has been a huge meeting. It has been a meeting where real practice-changing trials have been presented. It's been a meeting that has been an explosion of social media. The ESC have appointed over 50 social media ambassadors from all over the globe. There's been millions of tweets and impressions around all the exciting science of the ESC. So what are the trials that have really stood out in my view? Well, I think there have been a number. I think there's been trials like the COMPLETE trial. So the COMPLETE trial was a randomized controlled trial of over 4,000 patients presenting with STEMI, with multivessel disease. And it was a randomization between those that had revascularization, complete revascularization, either as inpatients or up to 45 days, versus target lesion only revascularization. There have been a number of trials in this arena in the past, and most of them have been very small and really underpowered to detect hard clinical endpoints. The COMPLETE trial is the largest today by several orders of magnitude, with over 4,000 patients. What this study showed was the composite endpoint of cardiovascular death and MI was reduced by over 25% in the complete revascularization arm. The other interesting thing about this trial was that it didn't appear to matter whether the complete revascularization was achieved in the in-hospital setting or following discharge up to 45 days. So I think it's the completeness of revascularization that matters rather than the timing of revascularization that matters. Will it change practice? I think so. I think it will very much change practice. I think there are some questions around, for example, whether the anatomical site is important. So, for example, there seems to be a significant PIFA interaction for proximal LAD, mid-LAD compared to other territories, and that would make sense in terms of the area subtended. Other trials that I think are really going to change practice are the ISO-REACT-5 trial. So we know that randomized trials comparing prasugrel versus clopidogrel and ticagrelor versus clopidogrel have shown superiority, but there hasn't really been an adequately powered head-to-head trial. There was one, the Prague trial, which was discontinued because of poor recruiting and secondly because of the low event rates. So, what did the ISR-REACT trial show? Well, this was a trial of over 4,000 ACS patients randomized to receive either prasugrel or ticagrelor. And they showed that the composite endpoint of death, MI, or stroke was associated with a 30% increase in the ticagrelor arm. This is interesting for several reasons. I think first and foremost, you were comparing a pre-treatment algorithm with ticagrelor versus a treatment algorithm after the angiogram following prasugrel. And so this is really telling us that perhaps we don't need to treat patients or pre-treat patients before the cath, and treating them at the time of the angiogram when a decision for PCI is made might be the right thing to do. There was no differences in bleeding outcomes, and certainly I think this will provide important guidance in the space. As interventional cardiologists, you know, looking around the UK, there's very different practices. We published an observational study using BSIS data 2 years ago, comparing prasugrel and ticagrelor, and again, prasugrel had better outcomes, but looking at practices of usage, very different in different regions of the country. And I think this trial ISR-REACT-5 will really give us guidance about optimal antiplatelet therapy in this population of patients. The other trial that I think was quite interesting, sticking with coronary syndrome, is the THEMIS trial. This was the large trial of over 11,000 patients undertaken in diabetics. This was in patients with known coronary artery disease without previous history of MI or stroke. And the primary outcome was cardiovascular death, MI or stroke. And this showed that ticagrelor compared to placebo was associated with a 10% reduction in the primary endpoint, although this was offset by over a 2.5 increase in TIMI major bleeding. And again, what we're seeing here, as we've seen in many of these studies, is a balancing act, a balance between reducing ischemic events versus increasing bleeding events. Whether there's any role for trying to identify the high ischemic, low bleeding, that's a nice concept. The problem with the nice concepts is that they often don't work in clinical practice. Often patients with a high ischemic burden are often those with a high bleeding burden. Moving on to heart failure, the two big heart failure trials have been, number one, the DAPA heart failure trial. This is with over 4,744 patients with an SGLT2 inhibitor randomized, and this showed a 26% reduction in heart failure events or cardiovascular deaths. SGLT2 inhibitors have been shown to decrease incident heart failure in the past, but this is one of the very first and largest trials looking at dapagliflozin and showing that dapagliflozin in both diabetics and non-diabetic individuals can reduce the composite endpoints. It can reduce cardiovascular death individually and heart failure related events such as heart failure hospitalizations or increase in therapy because of worsening heart failure. How will this change practice? I think this will really change practice hugely. I think one of the discussions is who should be starting dapagliflozin. Should it be diabeticians? Should it be cardiologists? Should it be the general medics? This was truly huge differences in the primary outcomes and secondary individual outcomes, irrespective of diabetic subtype. And also, this was a well-managed cohort. So I think, this is going to have a major impact in how we treat our heart failure patients. The final trial is the Paragon trial. The Paragon trial was using Entresto in patients with HFpEF, and the primary outcome was heart failure hospitalization and cardiovascular death. And there was no significant impact on outcome associated with Entresto. There did seem to be a signal that there was perhaps a significant effect in women. In the secondary analysis and secondary subgroup analyses, there was a benefit in patients with an ejection fraction of less than 57%, although I think this should be purely hypothesis generating. It certainly won't impact on my practice, on how I treat these patients. And I think really what it shows us is, HFpEF has a poor prognosis, and we really don't have that many effective treatments. So thank you for joining me. I think this has been one of the best ESC meetings to date. I've been very impressed by how global it is, the quality of the science, the quality of social media coverage and the organisation. So congratulations to the audience, and please let me know what you think are your favourite trials. Thank you.